That's great. Thank you. So we're moving on to the performance section, integrated quality and performance report. John, when John Teresa, well, a few John Teresa let us know that to receive the report, integrated quality and performance report.
The start off, thank you, Chair, and then turn to colleagues. So you've got the report in front of you, and I guess I'll just pull out some of the key things. So some of the areas of improvement, I think it's just worth highlighting around staff supervision, staff appraisal rates. I think as Anna alluded to earlier, we'll discuss a lot of details from quality committee. But equally, I think it is worth also recognising that we have got areas of concern that continue to have action plans in place against them, in particular risk assessment and care plans. And again, Anna and Teresa both talked about sort of through the quality committee how we're addressing those. We're also working through our divisional QPRs in terms of really getting into it. I think on both of those, what's important to note is that when you look not just at the trust level number, but at the divisional position, there is this relative difference. And in particular, the difference in the CAMS or specialist division is being significantly impacted by the issue that we continue to talk about around neurodevelopmental weights. And so the work we're doing around cleansing the PTL, so the sort of work around validating who's on PTL, all of those cases active, I think will help. But I think it would be disingenuous to say that there is an easy sort of solution to that. But we continue to implement the work that we said we were going to do at the start of the year. We're working through that very, and it's sort of linked in what's in the quality plan and through our sort of core priorities. You'll see all the waiting times information is in here as well. And I think within the waiting times information, the area that again it's worth just sort of acknowledging, the neurodevelopmental wait list continues to grow. And it's fair to say that our capacity continues to be constrained compared to the amount of activity and referrals that we get in. And so on that basis, that wait list will continue to rise. And we'll continue to work with partners across Sussex, and it will form, no doubt, a key part of our 25-26 sort of planning considerations of how collectively we're going to address those, including recognising that we may not necessarily be the sort of answer to all of that challenge and problem, and that there's going to have to be a sort of system-wide approach to it. The finances element of the IQR I won't touch on. We'll pick that up through the sort of finance section, some quality areas we've already said. I was going to say, to make best use of the time, Chair, I'm happy just to stop there and take some questions and particular areas that people want to go to, and we can delve into those.
Our waiting times, they're, as I understand it, they're not included in the national waiting times that we get reports back from our system, for example, about waiting. It's usually elective waiting times and related to acute services. I don't think ours are, the mental health waiting times are included.
In the
RTT wait.
Yeah, so in the RTT waits, the elective wait lists that tend to be for the focus of most of the attention, mental health waits aren't on that number. There is a move to a new set of standards for mental health waiting times. Those will get implemented. Don't tell me the exact time when they'll get implemented over the course of the year. I suspect there will be more focus once that is in.
In some ways, that might be quite useful for us in leading the way and influencing the solution programs via our system. Yeah.
Shall I come in on that?
Yeah.
So yeah, there's been some long discussed new mental health waiting times, which have been led by NHS England. They are about to be published, but they've been very clear that there will be no performance metrics monitored against them for this year.
Yeah.
So that would be from 25-26. Running concurrently with that, there will be a national publication of people waiting 104 weeks, and then 78 weeks, and then 52 weeks. At the minute, we've seen a very early cut of that data, and it really requires a significant level of validation between national data and local data. What we know is that the people who are waiting longest, as reported by us and reported by national data, are people who are waiting for neurodevelopmental assessments. There is a real correlation between the two. And that's no surprise to us. And we've spoken a lot before, and we in the board seminar and elsewhere around the challenges in the new developmental pathway. Chair, do you mind if I just draw out two bits of the report just before we move to questions? So just on waiting times, I think it's important to mention, so colleagues will see that there are children and young people waiting longer than 52 weeks. And you colleagues will see that there is a reducing number, but there is still 61 people at the point of publication waiting. This was the focus of discussion within our quality and performance review meeting last week with our specialist service division. And they have a trajectory for that, for all of those young people to have received their assessment by March next year. There's a number of assessments, additional assessments over the course of that period of time with some waiting initiatives in place. The cause of that is a bulge in referral activity 12, 18 months hence, particularly post-COVID. And it's particularly focused in Northwest Sussex. The only other area that I would draw out, because we touched on it earlier, I think Jane touched on it in her CEO report, is the focus on discharge. So without labouring something that I've talked about many times before, that our data tells us a story. It describes that we have a reducing number of people being assessed as needing to come into hospital over the past 18 months, 2 years. That coupled with what Jane's described in terms of the numbers of people being detained on a 136. However, at the same time, we have the numbers of people waiting to leave hospital flatlining, and the length of time that they are waiting to leave hospital is really problematic. So as a result, we have people waiting to come in, people waiting to come in for longer than we would like. And while there has been improvements in all those metrics, it is still an issue. Of a patient experience, a patient safety issue. In terms of, you'll see in the report describes a number of actions that we are taking in Sussex Partnership Trust to influence discharge. And you've heard through the board before a number of reports, particularly around the success of our housing programme. But we do have some really systemic issues that we need to challenge and take forward, and we simply cannot do them in isolation. So at the minute, we're currently working with an external organisation called Empower, who have been support has been provided to us from a bid that we put to the National Better Care Programme, working with our social care and ICB colleagues. So we're doing that piece of work at the minute. The aim of it is to develop a system-wide system improvement plan. And I think the key change that we've experienced over the last 12 months is local authority support and buy-in to having a shared improvement plan and a shared target and shared trajectory. That is a game changer. And I'm joint SRO for that work with one of the executives of adult social care. So that feels different. Now, the proof will be in the pudding, particularly as we head into winter. But I thought it was important to update the board on what is, I think, in terms of patient experience, clinical safety, in terms of the whole flow environment, probably our greatest risk. Yeah, I'm happy to take questions on any of the elements.
I really like the improvement programme, doing it with the local authorities, our local authorities in the system, and we'll get updates on that at future boards.
Absolutely.
Thank you. Friesel, did you want to come in?
Yes, please. So on the quality dashboards, and I've got the safety dashboard in front of me as I'm speaking. I just wanted to cast a slow lens in terms of the recovery of a number of these elements that are there on the quality and safety dashboard. So we know, and Anna made reference to it earlier, that when we apply practice development support within a clinical environment, we can make significant improvements quite quickly. And we know that through the reduction in ligature incidents of 50%. So we made reference earlier to the corporate services review. And one of the proposals that's going through that review is about really enhancing the role of professional nurse educator. And that role would take thematic learning from incidents, from the dashboard, and then a set programme of practice development that is applied out in clinical practice. I think once we've got that architecture, we'll start to see some real progress that's consistent.
Thank you very much. So we'll take questions. Abiona and Kathleen.
Just wanted to zoom in about, the waiting list. And I think we had this discussion before, but it's, 8-year waiting list on average in the UK, 9 for us. Just think of the people who are waiting on there for 8-9 years. I know obviously with children that they need to get that assessment because then it unlocks other things. So if children are waiting 2, 3, 4, 5 years, that means they're not receiving anything. Is there not a way, now that we're working, now we've got the buy-in for the council, the local authorities and the ICS, that they can access some services before getting that official, yes, you definitely have it. Is there some sort of more preventative services that they could?
You need to dispel a myth. You don't need a diagnosis to get services. There is agreement across Sussex that a diagnosis does not determine whether you get an EHCP in the plan for children. So it's really important. So that's something that's said quite frequently, and it's
Okay.
actually not true. So it is about the way the system is moving towards, because they're needs-based service rather than a diagnosis-based service. And so I think that reframing is really important. And it's with the local authority and the education department to make sure those packages of care are in place, but we manage the risk while they're on our waiting list.
Yeah, so then, but I'm glad that you raised that, because also if we're looking at the wait list, how many of the people on the wait list know that? And are on the wait list thinking that they need that diagnosis before anything happens. And so they're sitting there not doing anything for 8 to 9 years. Is there a way that the system to make sure that people are getting that message that you don't need to be waiting for this, you can do this? Actually, these are the services that you can access before before we say officially if you have it, because it's not going to kill the child. It could actually help you anyway. Just thinking that we've got to do something about that.
Yeah, so I think there are different issues, but children and young people and their families on the neurodevelopmental waiting list, and then adults, and obviously the waiting list for adults is far greater in the length of time than children, but obviously the implications for children is significant as well, particularly in those early years. So as Jane described, it's really important that all of our partners, particularly education, give the message that you don't need a diagnosis to get support in the school environment. So that's certainly a job of work that we need to continue to do with our system partners in communicating that. And many people's first interface will be in primary care through their GPs. And it's really important that that is communicated through GPs. So that's, I think, a piece of work that we can continue and refresh through the neurodevelopmental program. I think there is a comms message that we need to make sure is really clear. There's a clinical prioritization process that takes place within our services. So any of our patients, young people or adults who are referred for a neurodevelopmental assessment will be clinically triaged or clinically prioritized. And if they have a comorbid mental health issue or issues around risk, they will receive more urgent support than others that are a more routine referral. So there is that safety net, and people do get letters and they get signposted to other information. But for the scale, and I know this is where we talked before, the scale of people waiting and the resource that we have to manage the waiting list, there is undoubtedly a mismatch. And that's I think where the challenge lies.
It's probably worth saying, isn't it, that it's a really good question. And as a board sitting here thinking about years waiting times, we've got to do something about it. We did have a board for the public board meeting. We did have a workshop with the board not too long ago, where we had a focus around neurodevelopmental issues and neurodevelopmental waiting lists and what we should do about it. The answers are system wide, with our local authority partners, education and the integrated care system. And the chief medical officer that will replace you, Oliver Dale, outlined his plan for tackling this with our partners. So we need to come back to that because we need to rest assured best we can as a board that we're doing something about it. It's complicated, it's a big scale problem, and it does involve our partners as well as us. So that's just wanted to.
I completely agree, and I think Oliver described the primary care are a very key player in this, particularly in terms of the diagnostic space, because I know they're quite keen to think about something different. And that would be the program of work to pick it up.
Kathy's question, then we'll.
I was going to actually ask the same question as Alfio.
Yeah.
But the second one,
Yeah.
which is about the work you described, John, with working with the external consultants and with local
Yeah.
authorities on digital thing. And just to check, that will dock into the piece of work that Jane described at ICS level, because then you've got the weight of the ICS behind you as well.
Yeah, absolutely. So we have the Sussex system signed up for bid to be part of what's called the Discharge Front Runner program, and that predominantly was focused on acute trusts and frailty. Because of the scale of the mental health challenge, we established a mental health discharge front runner group, which for us is very supportively chaired by one of the directors of adult social care. So we have that buy-in. It's in effect that group that commissioned this piece of work that reports directly into the architecture and the structure that Jane described. So yes, it absolutely does have the buy-in. There's an ongoing challenge for us, Kathy, for us to continue to raise the profile.
Yes.
Round is on. Jane.
So I think it's really important. The neurodevelopmental weights is a system issue. It is not an SPFT alone issue. And it has to be seen as such. And as such, I'm the chair of the Mental Health Learning Disability and Autism Board. And there are papers, which is a system meeting, not an SPFT meeting, where there are papers coming around how we tackle the ADHD, ASD, neurodevelopmental waiting list, because they are held across our acute partners, our community partners, us, and the voluntary sector and health. So, and I think it's important we don't see this just as something in SPFT, because otherwise we miss all those other people on the list and we have the wrong solution. So I've asked for a paper and a deep dive to come, Colin, is it January? November, gosh, later. So you're right, actually, because we were trying to think about timings, weren't we? So it's coming to the board in November, which is led by the ICB. No, the Mental Health Learning Disability
Yeah.
Autism Board.
No, that's great. I know probably want to continue this, but we'll need to move on. But thank you for that, for wrapping that up. The Finance Investment Committee, that was Simon.
So I'll take the paper as read. I think the main thing which we will need to have a conversation put onto the board is around the green plan delivery, because there will become a business case to finance the investment one to get your steer beforehand. So we just need 10 minutes on a future board meeting to discuss that. And then the only other thing I think it's worth drawing attention to is the fact that there's very little left in the contingency pot for the Coombe Valley hospital programme. There isn't anything that we can do about that at this moment in time. But I think it's important to note it. And then finally, I guess the good news of the NHS providing support for the ward, Brunswick ward, is sort of noting it has moved timing and sequencing around, but it was worth having that investment for this year. And then finally, I think just to say there is evidently so much work which goes on financial recovery plan, and the level of detail that we're provided with in response to the questions is impressive. It's my view, Abiola and Neil, would you agree with that? And welcome that we have more NEDs in the meeting and more questions, and they're still able to be answered. So thank you to everyone for that. But any questions from?
Thanks, Simon. On the contingency plan for Coombe Valley, that as you described, the only thing what we can do is ensure that our system partners are aware, which we will and done, and also the national team, mental health national team. I have a meeting with them coming up to raise it. Okay, thank you. Thank you very much. And so moving on to the finance report. Ombudsman.
Thank you, Chair. So if it's okay, just I want very briefly just to, I guess, just because noting to Abiola's previous question and not to go back on things, Chair, the wait times for children and young people clearly, as we've all discussed, I guess just for accuracy, just to say the 8-year time was specifically for adults. For children, it is much lower than that. I think at the moment it's about 308 days is the average, and I guess it's just putting that context in there, notwithstanding everything else that was said. For the finance report, I won't. Simon's covered off the sort of key issues. We covered off the Finance and Investment Committee, just to say them. For month 5, we reported both in month and year to date on plan. So we reported an actual deficit of £10.8 million year to date till the beginning of August, which means that we're on track to deliver our £18.6 million plan deficit for the year. The key things I just wanted to draw people's attention to is if you were to look at the run rate slide on page 8, you will see, and I think it's just worth acknowledging the work, but at the same period last year, we were spending almost £3 million a month on agency spend. And this month, we are down at 1.977. So August 24 is August 23. That is a really significant reduction. And I think it's testament to the hard work, but also hopefully gives assurance to sort of the rest of the actions that we're putting in place and the things that we say we're doing in terms of the financial recovery. In terms of the financial recovery plan itself, you will see on slide 10 that we have delivered year to date about 97% of the plan, which is really great. And I think, again, speaks to the hard work of people across the organisation in order to deliver that and the change programmes. But it absolutely is obvious that looking at that the scale of the delivery ramps up significantly from December onwards. I think where we sit at this point, we've done a lot of work over the summer in between everything else to make sure that we're assured that that will happen. And I think at this point, we are confident that despite risks, we will deliver the plan as we set out at the start of the year. And we'll clearly continue to have further discussions about that. Beyond that, I'm happy to take questions. Look at the chair looking at me.
Always very interesting.
Last point, just to draw out then, is just as ever at the start of this year, we talked about there was a really significant focus around workforce. So you'll see on our workforce plan that once we adjust for the very exceptional package of care that we talked about previously, we are on track with our workforce plan as well. So I think things stand at this point in time, we are on track on all of the fronts through the sort of finance workforce plan that we sort of set out at the start of the year. Happy to take questions.
Thank you, Usman. Yeah, very open. I mean, a good report, lots of progress with Teresa and Anna.
Thank you. So I just wanted to come to the point that has been made about the agency staff reduction, and just to clarify that the fill rates in our inpatient wards are safe. So what I wouldn't want us to think is we've reduced our staffing, because we haven't. So as I've discussed in previous meetings, our fill rates for registered nurses average around the 95%. We have contingencies in place when we do have less than the registered nurses per shift, which is fairly rare. And our fill rates for our healthcare support workers is always above 100%, and that's usually aligned with acuity. And also linked to that is the significant reduction in our registered nursing vacancy, to go to the point that has been mentioned in relation to the workforce metrics. It's just really important that we're squaring off the finance with the quality and the safety, which is what I want it in.
Thank you very much. Anna.
Thank you. Just pulling that through. I just
Yeah.
a very quick question, curiosity about the underspend on CAMS and primary care.
So in both cases, that is not as a result of a financial recovery action. We would like those staff to be recruited to, but there are sort of, as we've discussed here, long-standing challenges with recruitment into those teams, and we'll sort of continue to work through plans to help sort of in effect replace our agency staff with permanent staff. But it is a challenge. Even finding locum staff is a challenge in some of those areas. And then we expect within primary care that to improve as sort of new sets of trainees come online. So it's something that absolutely is not sort of part of a specific recovery program, but it is a byproduct kind of where we are with workforce challenges in some specific areas.
Sure.
Thanks. It may be very detailed, Anna, but I guess to give you some reassurance with your quality hat on. So we took some very specific discussions through our exec committee around the talking therapies improvement program, and made a decision not to take that forward in Brighton and Hove for the attrition and the workforce challenges and the potential performance issues that you would see in here. And the same for CAMS. So community CAMS did not have an additional CIP for this year. Because just going back to Abiola's point in terms of waiting lists, so the correlation between the two. So it's nuanced.
Okay. Thank you. That's helpful.
Okay. I just want to thank you, Usman, and your team for doing all that you do on the finances, managing the finances, and the people around this board here that are leading on the quality as well and matching that together, because it's a huge challenge. Thank you very much. So we can move on to our audit committee reports. Nitin, good afternoon.
Afternoon, Chair. I will take the report as read, and ask the board to note the contents of the report. Couple of things to highlight. One, to note the challenges associated with the recruitment of additional lead psychiatrists to undertake consultant and specialty and associate specialist job planning. We had limited assurance for this particular topic, and we've had some time to review it at the committee, and would love for to note it for the board as well. The second thing we wanted to note was the internal audits review of commissioning and provider collaboratives, which had got a reasonable assurance as well. The internal audits recommendation is that the management hold a specific workshop focusing on provider collaboratives, with the committee's suggestion that this be incorporated into a future board workshop. And finally, to note is the digital and cyber security assurance report that we reviewed at the last audit committee. This will be an annual report and will come back to the board every year from now on. Happy to take any questions from anyone.
Thank you, Nathan, very much indeed. Any questions? Thank you, Nathan, very much.
Thank you.
Yeah, so moving on in the same vein, Charitable Funds Committee report. We met fairly recently. There's no issues that we need to escalate to the board at this stage. It's just really to receive it from our board's point of view. There were a number of funding applications for the charity, which we considered and approved. And I wanted to, sorry, Jane, I didn't ask you this, but there was the Heads On charity event, which, well, would you please? Yeah.
So it was wonderful. There were 5 executive directors with their families there, and also Kevin, one of our Neds, attended as well. We've raised over £7,000. It was at the Glyndebourne estate, a 5k or a 10k flat walk, or as Colin found, a 10k very, very steep uphill climb, I'd say.
Well, Kevin's feedback was he thought he was a hill runner before he did it. Now wondering if he's still a hill runner after he did it.
And I think that's one of we had a service user who benefited from the charity previously, who came and did it as part of her well-being and gave some really positive. It's 10 years ago since she was an inpatient, and this is 10 years anniversary of these walks starting. So I encourage you, as soon as the dates come out next year, to sign up with your families. It was lovely. It was a really nice event, and thankfully it wasn't raining.
No, it's very good, and we will take note of that, get the date in for next year. That's fantastic. I mean, it's a good charity that we support, and it's even better that Usman is nodding away, because of course, you know, we need to ensure that we give it the right support financially as everything else. Rachel Duke is our director, so she's not able to come today to give us a quick report, but just thanks to her with all the work she's been doing. Thank you very much. So, coming towards the close of the meeting, review of the trust constitution. This has come about as a result of a number of things we need to change. And Usman, would you take the lead on?
I'll just take us quickly through this. I know you're all scintillated by our constitution. So we agreed to look at the trust constitution in 2 phases. So there was phase 1, which was just to make sure that in the light of all of the legislative changes and other sort of graphical updates that needed to be made, we would make those, as well as looking at board composition. That is what we're going to just talk about briefly here. Phase 2 was the work that many of you are aware of, that we've been doing around our governors, but that report won't come to. So we're just really looking at the phase 1 element of this, which is around some of the updates that we needed to make to the constitution, plus board composition. Without going through all of it, I guess just to summarize, in effect, what we are proposing is that we would increase the executive voting members of the board by 1 to 8, and that we would also increase the non-executive number, so that we maintain the constitutional position, that is, that there are more non-executives and chair than there is the voting members of the board. So we would ask for that approval, recommend it for approval to the Council of Governors, and Also then just to recommend for approval some of the changes that we've made to non-current chair and wording sort of replacing monitor with NHS England as a result of all of the changes that have happened there. So I'm happy to leave it there, Chair, and take questions if anyone has any specific questions to ask. But I guess just final thing I shouldn't sort of just said is we did also seek legal advice on this to make sure that we are compliant with not just our own constitution, but with the wider position, which is in the documents that you will see from Bev and Britain. That what we are proposing is completely from all the constitutions.
Question for Simon.
I guess I just have one question, which is there may not always be 9 NEDs. And I'm sorry, I haven't read the paper after said, and I will blame my computer problems probably, you haven't heard about those. But if there aren't 9 NEDs, does the chair get the casting vote?
Yes.
Yeah, okay.
Good. So we need to approve, so do we have approval to recommend to the Council of Governors that we make those changes?
And then-
Chair, just one question.
Oh, no, sorry.
From me earlier, reminded me that this is a unitary board. The environments I live in, those with the deepest pockets usually get a casting vote. Given that it's a unitary board, should there not be equality between executive and net with casting vote going to the chair? I think that's a positive message. It's consistent with our fidelity with the trust values, in my estimation. I know it may be done differently elsewhere, but if we want to do things in the way that I'm hearing, you can always get around convenience, always.
Isn't it just isn't it either 9?
I think there's some.
Yeah, sorry, let me clarify, sorry. So by these changes mean we would have 8 executive voting directors and 8 non-executive
Sorry.
directors,
Yeah.
sorry. 9
There was one.
including the chair, yeah.
Sorry, I should.
I included the chair.
Yeah.
Yeah,
Yes, yeah.
so to your point, it would be even,
Yeah.
Sorry.
Good. Anna.
So, and just to follow through, I think, this has come from many disasters in the NHS, so for many decades of too much power and control being, with the operational side. So I think there's a history to why NHS trusts and foundation trusts, have that kind of balance in the same way that I think for national, public boards, the idea, the concept is that the non-execs, are slightly outnumber the execs in order to maintain that kind of equilibrium and challenge, because if you're not in it, then you're slightly can step back a little bit, and you're not quite as vested in it as an exec team is, and therefore you might spot things, as we hope you do, that the exec team don't. So I think that's the reason that there's that.
Yeah, thank you, sir. Thank you. Yeah, great. Okay, we've approved it to go to the Council of Governors. Thank you very much. Any other business? I haven't received any, but if there's any other business. No? Thank you very much. We're closing a little early.